Hi everyone, welcome to today's live webinar with LACNETS. Today we have special guest Dr. Edward Wolin, and he'll be speaking about advances in neuroendocrine tumor therapy. I'm Lindsay Judovine, I'm the Director of Communications for LACNETS, and this is...
I'm Lisa Yen, I'm the Program Director for LACNETS.
Before we begin, we'd like to extend a special thank you to Rich at TVP Live for making all of this possible. And just a reminder that if you have any questions during today's program for Dr. Wolin, you can go to Slido, SLI.do, and enter event code Wolin, WOLIN, and submit your questions there. We'll be having a live Q&A towards the end of the broadcast. A few tech tips before we get started today to make sure you can hear and see us. For audio, be sure the volume on your computer is turned all the way up. Double check that the volume is unmuted on the webinar broadcast screen, super important. And then for the video, you can enlarge the webinar broadcast screen by clicking the expand screen button in the bottom right corner of the webinar screen. An important reminder, patient advocacy groups is an important source of net news and resources. So we encourage you to sign up for the LACNETS newsletter. You can do that on our website and follow us on our social media. We have a Facebook page, Instagram, and Twitter. You can follow us at LACNETS. And now, Lisa, I'll hand it off to you for a brief history of LACNETS.
Thank you, Lindsay. We want to extend a special welcome to those of you who are joining us for the first time and tell you a bit about who we are. As you may already know, LACNETS stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. The LACNETS team includes Donna Gavin, who is the sister of Giovanna Joyce Mbesi, the founder of LACNETS, Lindsay Judovine, who you already met, our Director of Communications, Kavya Velagapudi, our Interim Administrator and Board Member, and myself. We're also grateful for the help of our advisory board. LACNETS was founded in 2012 by Giovanna Joyce Mbesi as a Los Angeles-based neuroendocrine cancer advocacy group. We have extended beyond a local reach and now have a wide global reach as well. Our mission is to provide support, education, and advocacy for all people impacted by this rare disease that used to be known as carcinoid, which is an old term for what is now called neuroendocrine cancer, neuroendocrine tumor, or NET. As many of you already know, NET was made famous by Steve Jobs and Aretha Franklin, who lived with NET for many years. It's a type of cancer where people often experience delays in being diagnosed for many years, on average 5 to 9 years, according to some studies. So at the time of diagnosis, the cancer is often already spread or metastasized to other organs. It's a type of cancer that while it may not be curable when it's found after it's already spread, it is treatable. And because it tends to be slow growing, people can live with it for many, many years as a chronic disease with the appropriate treatment. Unlike other types of cancer, there isn't a clear treatment algorithm or pathway. Instead, as NET expert Dr. Eric Liu said in our July webinar, the NET cancer journey often looks more like a spider web. So there's a huge need for education, advocacy, and support through the ups and downs of living with NET. One way LACNETS strives to provide education, advocacy, and support is by voicing the patient's perspective in collaborative dialogue with healthcare professionals. We have a robust program that includes monthly educational webinars, which have always been live broadcasted and recorded, but now, due to COVID, are solely webinars. We also have an annual patient education conference, which was done virtually in June this year. And all videos of our past educational meetings, webinars, and conferences can be viewed on our YouTube channel, which Lindsay already mentioned. So we encourage you to check out our YouTube channel and remember to like and subscribe. We're excited to share with you our educational webinars for the rest of 2020. In October, our speaker will be Dr. Shirley Paskey, gastroenterologist from Cedars-Sinai Medical Center in Los Angeles, who will discuss one of the most popular topics in the NET patient community, diarrhea. It's a common symptom that many NET patients struggle with, and it affects our day-to-day lives. So we hope this educational webinar might help. Be sure to mark your calendars for our virtual NET Cancer Day Symposium on Saturday, November 7th. This is a special half-day event featuring NET experts, including Dr. Dan Lee from City of Hope, Dr. Sandy Kotai from Mercy Medical, Dr. Dira Del Rivero from the NIH, and Dr. Banerjee from City of Hope. You'll hear the latest in NET cancer research, and you'll also hear stories from NET patients or caregivers. Our December speaker is Chaplain Michael Echelon from the UCLA Sims Mann Center for Integrative Oncology. He's given several TED Talks, and it's always a real treat to have him as our guest. I always love hearing from him, and it'll be an inspiring time where we get to hear his stories and insights. Virtual support groups that are done weekly via Zoom on Wednesdays at noon have been a real special time to connect with other patients and caregivers. It's a time where we share our experiences and learn from each other. We now have a helpful how-to video for those who are new to Zoom that will be emailed to you after you register for the meeting. NET caregivers are welcome to join us for a monthly NET caregiver support group that meets monthly, virtually via Zoom on the last Saturday of every month. Our upcoming NET caregiver support group will be Saturday, September 26th. It's facilitated by palliative care physician Dr. Banerjee from City of Hope and her colleagues. And another way to get connected is through a buddy system called NET Connect, where you're welcome to connect with someone else on this journey for peer support. Some people might reach out to connect with someone who has had a certain treatment or surgery that your doctor has suggested for you. Others might want to talk to someone who has the same type of NET, or you might just be looking for some help from someone who's a little further along in the journey. This is especially helpful for those of you who are newly diagnosed. So please reach out to us, sign up if you're interested. NET Vitals is a downloadable 20-question communication tool that highlights the vitals of your NET cancer. So these are the important things that your NET expert wants to know when you see them for an appointment. So if you're going to see a NET expert for a second opinion or consultation, you can download this form and fill it out before your consultation. This will help you get on the same page in terms of terminology and also help you get to know your own disease. Filling out your NET Vitals as homework to prepare for your appointment can be empowering as you learn to speak NET and know the details of your own disease. It also helps you make your appointment more efficient. The time is then better spent because it prepares you to ask smarter questions, such as the questions that come up when you're filling out your NET Vitals. And instead of spending your appointment defining NET terminology, you could spend more time talking about the things that matter, about your treatment and how to improve your quality of life. So we're also thrilled to share that NET Vitals will be featured in the upcoming conference for medical professionals called NANETS, the North American NET Society, in October. And Dr. Dan Lee from City of Hope will be giving an oral presentation to the medical professionals about how NET Vitals has helped the LACNETS community. It's an honor to be featured. We've written many educational blogs on a variety of topics, including PRRT, research, running this marathon of the NET journey, finding calm during coronavirus, and many, many more. So please check out our blogs. And quizzes is something fun that we welcome you to check out as well. We've written several short quizzes that's a fun way for you to test your understanding of all the information and education that you've been taking in. Our NET quizzes go along with the NetRF's NetWise podcast. So if you've listened to a NetWise podcast, pop over to our quiz page and take a quiz. If you haven't yet checked out the NetWise podcast, go to our quiz page for the link to listen to the podcast and then take the quiz after you listen to it. We're honored today to welcome Dr. Edward Wolin, medical oncologist and director of the Center for Carcinoid and Neuroendocrine Tumors at the Mount Sinai Hospital in New York City. He was the inaugural speaker of the LACNETS Patient Educational Speaker Series with the launch of LACNETS 8 years ago, back in 2012. Dr. Wolin worked very closely with our founder and executive director emeritus, Giovanna Joyce Mbasi, as a featured speaker for many of the monthly meetings and the annual patient education conferences. Giovanna and Dr. Wolin shared a passion to help the NET community, as well as a love for music. Dr. Wolin is a NET expert and personal physician to many patients. He's also a colleague and fellow advocate, and he's a friend. He's a friend to Giovanna, to LACNETS, and to the whole NET community. Welcome, Dr. Wolin.
Hi, everybody. My name is Dr. Edward Wolin. I'm a medical oncologist, actually a neuroendocrine oncologist, and I've been taking care of people with neuroendocrine cancers for over 25 years as my major activity. I was at Cedars-Sinai for many years before I ended up in New York, where I'm now the director of the Carcinoid and Neuroendocrine Tumor Center at Mount Sinai. I was previously at Cedars-Sinai in Los Angeles for many, many years before I moved to New York, and was involved in the founding of LACNETS with Giovanna and Bessie in 2012. And the last time I spoke to this illustrious group was in the inaugural meeting in 2012. And Giovanna and I have been in very close touch for many, many years. I first met her in 2009, and the last time I saw her was in 2018, which was about a year before she passed away, unfortunately. And she's just been an incredible force in the world of neuroendocrine cancer, a huge inspiration to patients and an inspiration to all of her doctors as well, with her amazing attitude, her cheerfulness, her creativity. Her musical contributions to healing have all been just wonderful. And I think we owe a great big debt of gratitude to her. And if it were not for her, we wouldn't have the LACNETS organization. She's really an inspiration. I first became interested in neuroendocrine cancers many years ago when in one year I saw 3 people with neuroendocrine tumors who were dying of complications of cancer, which they didn't even need to be dying from. And I said, my goodness, something needs to be done. And then I looked into it, and at that time, there were no treatments at all for carcinoid tumors. Neuroendocrine cancer was something that people just were watching and not doing very much. Some things were starting to happen in Europe, a little bit ahead of the United States at that time. But it was really dark ages for treating neuroendocrine cancer. And at that point, I just focused all of my energy on carcinoid and neuroendocrine tumors, developed a big center at Cedars-Sinai and subsequently at Mount Sinai in New York, and was instrumental in the development and FDA approval of such things as lanreotide and everolimus and PRRT, which we now use routinely in treatment of these diseases. But remember, in the beginning, we didn't have any of these things. It was only because of clinical trials that allowed this to happen. So it's a great pleasure to speak with you, and I'll be talking about where we are in 2020 in treating neuroendocrine cancer. The talk I'll be giving right now is on the current management of neuroendocrine cancers at Mount Sinai, but also in the United States right now at specialized centers. I think that I will first give you an introduction to neuroendocrine tumors, try to get everybody on the same page so we all know what we're talking about. And I'll be speaking for about half of the session today. And the second half will be a chance for all of you to ask questions. And I'll do my best to answer everybody's questions. The prevalence of neuroendocrine cancer in the United States has increased remarkably, and it's now more prevalent in the United States population than stomach cancer and pancreatic cancer put together, which is really a remarkable increase. In fact, there are about 500% more cases in the last 30 years. Amazing, presumably due to something in the environment, but we haven't been able to figure out what it is. Now, this is something that is also quite remarkable, that people are going to doctors over and over and over without a diagnosis being made. And this goes for years in many cases without a diagnosis. This was a study that I was involved in with a sample of 758 patients in the United States. We published this in 2015, and we looked at how long it took for people to get diagnosed. And 34% of patients had over 5 years elapsed from the time they presented with severe symptoms to the time they were actually diagnosed with cancer. That's a remarkable period of time for people to be suffering, sometimes with horrible diarrhea, flushing, or other problems. The average patient went to 6 different physicians or healthcare providers and had an average of 13 doctor visits. And many of these were to emergency rooms or even hospitals before somebody thought of the diagnosis and did the simple tests which are necessary to prove it. People were told they had irritable bowel disease, gastritis, anxiety, psychosomatic problems, inflammatory bowel disease, asthma, hot flashes from menopause, ulcers, psychiatric disorders, and so on. Just um, people suffering, doctors thinking patients were crazy, and it made it so hard. Even in the case of Giovanna, it was something like 5 years that elapsed between the time she had severe symptoms and the time she was able to be diagnosed. Now, when we think about neuroendocrine tumors, before we talk about treatment, let's all be on the same page so we know what we're talking about. Because there actually is a whole family of neuroendocrine cancers, and there's a very peculiar classification system for these cancers. They're classified according to where the cancer would have started if the patient were an embryo. So on the right side here, we see an embryo, which doesn't look quite like an adult person. And you'll see little arrows pointing to places where organs are later on going to form. In an embryo, there's an intestinal tract area, has a foregut, a midgut, and a hindgut. None of these things exist in adults. We don't have a foregut, a midgut, and a hindgut, but only in an embryo. But you have to say, if you were an embryo, what tumors would have happened in the foregut? And these are the neuroendocrine tumors, thus esophagus, lung, stomach, duodenum, pancreas. Then there's midgut neuroendocrine tumors, appendix, small intestine, the early part of the large intestine, and the so-called hindgut tumors, which are the rectum and the adjacent colon. That's called hindgut. Neuroendocrine tumors, in addition to being classified as to where they come from, are classified by grade. Now, grade needs to be distinguished from stage. Stage means how advanced the cancer is. Grade means how fast the cancer is growing. And this is the current World Health Organization classification for grade. The well-differentiated tumors are the ones that are dividing more slowly. Poorly differentiated are the ones that divide the fastest. And the well-differentiated are divided up into grade 1, grade 2, and grade 3, according to how many cells are undergoing cell division. And by doing a chemical test of the cells called Ki-67, you could count the number of dividing cells. So the first thing is the site of the cancer. The next thing is the grade of the cancer. The next thing is, does the cancer produce hormones? A cancer which makes hormones is called a functional neuroendocrine tumor. This can happen in any type of neuroendocrine tumor, since after all, it comes from an endocrine cell. In the case of patients with carcinoid, you can have the production of serotonin as well as a lot of other chemicals. And these chemicals cause flushing, diarrhea, and in advanced cases can even lead to heart disease and can lead to other complications. So this is called carcinoid syndrome. People that have pancreatic neuroendocrine tumors, the majority are not producing hormones, but when they do make hormones, they make different hormones that are classical for pancreas. So they can make insulin, and those tumors are called insulinoma and can make your blood sugar dangerously low. It can make glucagon, which can raise blood sugar, among other things, and it's called a glucagonoma. A gastrinoma makes gastrin that makes the stomach make too much acid and cause lots of ulcers, and so on. There are lots and lots of hormones that can be made. These are just a few of the more common ones. Now, to diagnose a neuroendocrine tumor, primary site of origin is sometimes difficult, especially since the single common place that they start is in the small intestine. There's a special type of endoscopy to look at the small intestine called double balloon push enteroscopy or double balloon push endoscopy, where a gastroenterologist can insert a tube into the small intestine through a colonoscope and can actually scope the small intestine. There's a technique called wireless capsule endoscopy where you swallow a camera pill. And there's special type of CT or MRI for visualizing small intestine. In the case of pancreatic neuroendocrine tumors, which are small, an endoscopic ultrasound can be done through a upper GI endoscopy, and pancreatic tumors can be seen and even biopsied that way. Now, there also are some specialized imaging studies for looking at neuroendocrine cancer. An MRI with EOVIST contrast is extraordinarily good for looking at liver metastases, and that would be one of the very best ways we have for looking at liver. It seems that it's even better than a normal CT. There's a special type of CT called the triple phase CT that's a little bit better, and that can be used as well. The gallium dotatate PET CAT, which we'll be talking about later, is an amazingly sensitive test, can pick up most people's liver metastases as well as metastatic disease anywhere in the body if you have the so-called somatostatin receptors. Again, we'll be talking about that test later, and you should note that this test has replaced the Trioscan, which, as far as I'm concerned, is an obsolete technology, which gives a very, very blurry type of a picture. Carcinoid syndrome, I'm going to talk about a little bit more because it's one of the most common functional syndromes from neuroendocrine cancers. And it basically involves the skin becoming red without sweating. This is different than, for example, menopausal hot flashes where you have sweating as well, or blushing where you have sweating as well. This is just redness, sometimes associated with burning and warmth. Redness is most prominent on the face and the neck, but it can also extend to other parts of the body. All flushing from any cause is due to increased blood flow in the blood vessels that are near the surface of the skin. And since the face and the neck have the thinnest skin, you get the blood vessels under the skin most easily. So most flushing starts in the face and the neck. This is a typical picture of a carcinoid flush. Carcinoid diarrhea is also a little bit different than other types of diarrhea. It's what we call a secretory diarrhea, where the intestines keep secreting large quantities of fluid. This can happen even at night, even if you're not drinking, it'll just keep making diarrhea until the point you're dehydrated. It's a very big problem, and there are ways of distinguishing this type of diarrhea from other types with the so-called osmotic gap. Carcinoid heart disease is a complication of having very high serotonins, usually for a long time, and is a complication of carcinoid syndrome we try very hard to avoid. Most people have serotonin levels greater than 1,000, urinary 5-HIAA greater than 57. You get scar tissue forming throughout the heart, particularly severe tricuspid and pulmonary valves. And in cases where it's bad and those valves become really leaky, you can develop heart failure and need to get heart surgery actually to replace the tricuspid and pulmonary valves. And when that's done, people do extraordinarily well, can tolerate treatments, and can live as long as people. But if you don't replace the valves when you really need to, it's a very dangerous situation. When you have carcinoid syndrome, not only can you get scar tissue forming in the heart, but you can also get scar tissue forming in the abdominal cavity, which is called the peritoneal cavity, and that can cause intestinal obstruction. And you can get it in the area behind the abdominal cavity called the retroperitoneum, and that can block the tubes to the kidneys. So these things have to be watched for and treated appropriately if they happen. It can also happen that blood vessels in the abdomen can be blocked by scar tissue, and sometimes this can be a problem and sometimes needs surgical interventions. Now, how do we treat a carcinoid tumor? The first thing is primary tumor and metastases are typically taken out surgically if it's technically possible. It's not always technically possible, and you need to have a very, very highly experienced surgeon to do this type of operation. But we certainly have some on both the East Coast and the West Coast who are able to do this. Ideally, you want to be able to remove at least 90% of the tumor, and it looks like people actually live longer and certainly better. If anybody has metastatic carcinoid where it's already spread, it's recommended to have your gallbladder taken out at the same time you're having an abdominal surgery, because there's approximately a 50% risk of gallstones if you use octreotide or lanreotide, and it makes subsequent treatment of your liver safer as well. But so taking out the gallbladder doesn't really add much to the surgery if you're already working in that area anyway, and it's a good idea to do it under those circumstances. By removing a primary intestinal tumor, you prevent obstruction, bleeding, or other complications. And if it's feasible to take it out, it's a good thing to do. Now, another thing that we can do is treat liver metastases with liver-directed therapy. One of the peculiar things about intestinal carcinoid tumors and also pancreatic neuroendocrine tumors is that the blood leaves those organs. It does not go into the general bloodstream. Instead, the blood from the intestine and pancreas goes directly to the liver to get filtered. So by doing that, you bypass the rest of the body, and you could end up having cancer cells from the small intestine or pancreas go directly to liver and getting stuck in the filtration system. You could end up with 20, 30, 50, 100 tumors in your liver without any metastases anywhere else. It's remarkable. And then if you get metastases to other parts of the body, it usually comes to liver first. But the liver is a big problem. If the tumors in the liver are not surgically resectable, another way of dealing with them is what's called embolization. This can be done with bland embolization, where you just block off the arteries, done in the interventional radiology department with a catheter. It's a little bit like a heart cath, except it's a liver artery cath. There's also a technique called chemoembolization, where chemotherapy can be put in at the same time. We're currently doing a prospective trial to determine if chemoembolization or bland embolization is the better thing to do. It's a national trial which is still ongoing, but both of those are good procedures. We tend not to use radioembolization in neuroendocrine tumors with Y90 because that's a type of embolization that may make it more dangerous to have PRRT in the future, which is something which more and more neuroendocrine patients are having. The RETNet trial is a randomized trial of bland embolization and two types of chemoembolization to see whether the suspicion that chemoembolization is better actually turns out to be true, and also to see whether the extra toxicity of chemoembolization is worthwhile because of this. So we really don't know the answer, and an ongoing trial is taking place right now. Now, how do we figure out what to do for individual patients? This is the model which I developed when I was at Mount Sinai, at Cedars-Sinai first, and then we now have at Mount Sinai in New York. We have a Neuroendocrine Tumor Board, a tumor conference that meets every single week with all of the specialists you can see here in this little circle to discuss the patient. In the middle of the room is not an elephant, but a zebra, the NET patient. That's what this is all about. And all the different specialists, medical oncology, endocrinology, surgery, and all different surgical specialties in radiation and cardiology, gastroenterology, pathology, interventional radiology, diagnostic radiology, nuclear medicine. We all get together and discuss what is the optimal management for this particular person after we all look at the pathology and we all look at all of the radiology together, the imaging studies, and we can determine what are the best options and what are the best things to do. And it's a tremendous way of optimizing, individualizing patient care. This is a slightly busy slide, but I wanted to emphasize the fact that in the last decade, there's been an explosion of proven effective treatments for neuroendocrine cancer. Remember I said when I started this field, there was absolutely nothing except for one old chemotherapy drug for ones that started the pancreas only. That's been around since the 1980s. After that, nothing happened for years until 2011, where in rapid succession, we developed everolimus, cemiplimab, lanreotide, everolimus for other types of neuroendocrine tumors, talotat, and PRT with lutetium-177 dotatate. This is amazing. All this happened in a 10-year period, and there's a whole another generation of clinical trials that are maturing, and we'll have another batch of treatments coming even faster and faster. So there's tremendous hope for people with neuroendocrine cancer. And any statistics you read about how many people are living 10 years later and that sort of thing is already ancient history because none of these treatments were even around 10 years ago. So just be aware that this is really a very exciting time for neuroendocrine cancer treatment. Now I'm going to talk a little bit about some of the treatments that we use. We call systemic treatments, treatments that treat cancer in the whole body, not just directed at the liver, not just directed at the primary tumor, but able to attack metastatic disease wherever it is, whether it's liver, lung, bone, can be anywhere. Okay? And we'll talk about various classes of treatment. The first class of treatment that I'm going to talk about is treatments which target the somatostatin receptor. This is something I'm sure you've been hearing a lot about, but most people are very confused about. The somatostatin receptor is a little spot on the surface membrane of neuroendocrine cells that is able to interact with a hormone called somatostatin. And most neuroendocrine cancers, the vast majority, have these somatostatin receptors on their membranes. Okay? When somatostatin interacts with these receptors, it's able to stop cells from growing. It's able to make them stop producing hormones. It makes carcinoid syndrome and other hormone-producing syndromes better, and it can stop cancer from growing for years. 80 to 90% of neuroendocrine tumors have somatostatin receptors. Now, we don't use somatostatin as therapy because it lasts only 2 or 3 minutes in the body. And that isn't a very practical medicine. It only lasts 2 or 3 minutes. So somatostatin analogs have been developed. And these somatostatin analogs, like octreotide and lanreotide, have a very, very long period of action. And octreotide LAR or lanreotide depot can last for 4 weeks before you need another injection. So it gives a continuous period of control for a long time, very conveniently. Native somatostatin doesn't have the ability of doing that since it has such a short lifetime in the body. Now, somatostatin analogs are incredibly well tolerated. If you see in this picture over here of toxicities from the most to the least, the highest ones are on the top, you'll see that most of the ones on the top, diarrhea, steatorrhea, which is malabsorption and excess gas and all these things, are due to an enzyme deficiency. When you use a somatostatin analog, octreotide or lanreotide, what happens is that you don't have enough pancreatic enzymes being produced, which go into the small intestine to digest your food. If that happens, you have a big problem where undigested food goes all the way through into the colon, and bacteria will eat it and ferment it and make gas. So the colon becomes a gas factory, and people are miserable with diarrhea, bloating, and all of these types of symptoms. So if anybody is having these gastrointestinal symptoms from lanreotide or octreotide, all you need to do is to use a pancreatic enzyme supplement. The most common brands are Creon and Zenpep, and you can prevent those symptoms. The gallstones are prevented by having the gallbladder taken out prophylactically, as we talked about, and the other symptoms are actually much less common. Now, this was a study which proved that lanreotide was a fantastic anti-cancer treatment. People were randomly assigned to lanreotide versus placebo. In fact, Giovanna was treated with this drug for maybe 7 years. She was one of the first people in the world to ever have this on a clinical trial, and also points out how incredibly valuable it is to participate in a clinical trial if a good trial is available that is an advance over current treatment. This is a busy slide, but don't worry about that because I'll tell you what's important on here is that people with intestinal neuroendocrine tumors were able to go for an average of 61.5 months. That's over 5 years with no cancer progression. And that's an average. Some people go for 10 years with no cancer progression, but the average is over 5 years. And with pancreatic neuroendocrine tumors, 38.5 months. So either way, people can live for years and years and years. And remember, these are statistical averages because individual patients sometimes can go for a very, very long time. It controls cancer better than any kind of chemotherapy we have. And in people who haven't been treated with anything else, gives amazing results. The next thing that happens with somatostatin receptors on cells is that we can use them as molecular targets for diagnosis and therapy. When you see over here in green that says target is the somatostatin receptor on the cell. When it says ligand, it means somatostatin analog, like octreotide. It's linked to a chelator that contains a radioactive isotope. You put in gallium-68, and that's called gallium-68 dotatate or dotatate, which is octreotide. Octreotide is the ligand. gallium-68 dotatate. And if you want to kill cancer with this, you put in lutetium-177 dotatate. This is called DOTA, this linker. So this is really how it works. It all targets the somatostatin receptor, and it only works if you have somatostatin receptors, which are easily proved by having a positive gallium dotatate PET. Okay, that's how it works. It binds to the cancer, brings the radioactivity to the cancer cell, and then internalizes it within the cell, and the cell gets nuked. This was the randomized trial which we did to prove the effectiveness of radioactive octreotide, the lutetium-177 dotatate. Half of the patients were treated with lutetium-177 dotatate, and the other patients had their dose of octreotide doubled from 30 milligrams every 4 weeks to 60 milligrams every 4 weeks to see if doubling the dose of regular octreotide is just as good as giving radioactive octreotide. The results were very clear. When people got radioactive octreotide, it controlled cancer in almost everybody. Approximately 20% of people, 19% to be exact, had a major shrinkage of cancer, but it only grew in 4%. People who got the octreotide double dose, hardly anybody had any response at all. 3% of patients had a partial response. So if somebody's cancer is progressing on a full dose of octreotide, namely 30 milligrams every 4 weeks, or lanreotide 120 milligrams every 4 weeks, then the next type of somatostatin analog therapy to consider would be PRRT, since doubling the dose doesn't make much difference. Progression-free survival is drastically different when people got PRRT, the upper line, versus no PRRT in the lower line. And the majority of patients are still doing wonderfully and have never relapsed all these years after the trial. So how do we decide who should be treated with PRRT with lutetium-177 dotatate? Certainly people that have metastatic neuroendocrine tumor in their gastrointestinal tract or pancreas. People who have well-differentiated tumors do best. People that can be grade 1 through 3. Progressive tumors on their MRI or CT. They have to have a positive gallium dotatate PET. That's really, really important because if you don't have the somatostatin receptors, there's not for the lutetium-177 dotatate to work on. Kidney function has to be decent. You can't have a creatinine worse than 1.7. You have to be strong enough to tolerate treatment. This is not a treatment for somebody who's dying of cancer and hope you can make them get better, because they have to be strong enough to tolerate it. And in our institution, we have a multidisciplinary neuroendocrine tumor team, as I talked to you about, and we always decide what is the optimal timing of PRRT versus embolization versus resection of metastasis versus other treatment. It's a major decision, and we do that as a team. Lots of new clinical trials are happening in PRRT. We don't know which ones are going to be winners yet, but we know a lot of things are happening. Right now, there are new kinds of molecules for PRRT that are somatostatin receptor agonists that may turn out to be an improvement. One that's been called JR11 or satoriotide is one that's fairly along in clinical trials. Intrahepatic PRRT, where it's given in the hepatic artery. PRRT in combination with drugs like everolimus or capecitabine. PRRT followed by immune checkpoint inhibitor therapy, which something that's very exciting you might have heard about. PRRT with new isotopes that might be less toxic, like so-called alpha emitters, and PRRT using new targets other than the somatostatin receptor, so that people who have no somatostatin receptors on gallium-68 PET still can be treated. So all of these things right now are being studied. One of the examples of PRRT for people who don't have somatostatin receptors is to use a drug which targets the so-called norepinephrine transporter, which is another thing that's peculiar to neuroendocrine cells. And we're developing clinical trials using that drug, and hopefully will be available soon. Now, gallium-68 dotatate I've been talking about for a while. It's a very, very potent imaging technique. This is from Dr. Richard Baum in Germany. You can see a CAT scan showing one tumor over here. Okay. But on the gallium dotatate PET, you can see there are two tumors that are very big, and you can see before being treated with lutetium-177 dotatate, they light up like little light bulbs. After one cycle of treatment, all gone on CAT scan, you don't see a thing, but the tumors are obviously still there on the gallium dotatate PET. Got a second cycle of PRRT, and it's disappeared from the liver even on the gallium dotatate PET, so the patient's in a complete remission. Instead of having 4 cycles, for some reason, this patient stopped after 2 cycles, had a relapse a year later, and the first place to find it was the gallium dotatate before it showed up on CT. So just be aware, this is an extraordinarily sensitive, powerful imaging technique, and it's really becoming very routine to use it in managing neuroendocrine cancer. This was a study that I did while I was at Cedars-Sinai in Los Angeles in conjunction with the nuclear medicine group at UCLA. And we looked at 100 consecutive patients and found that it changed management in 60% compared to people who didn't have a gallium dotatate PET. So it's an extraordinarily powerful and valuable test to do. The next molecular target after the somatostatin receptor is the so-called mTOR inhibitor. mTOR is a molecular target which is turning out to be important for neuroendocrine tumors. Now, why am I showing you this slide? These are heads of warriors in Easter Islands that were built hundreds and hundreds of years ago, and they've just been standing there, not blown away by the biggest hurricanes and cyclones. They weigh something like 120 tons. They're over 100 feet tall, and they're sitting on the grass where there's no rocks anywhere. How these things were built, how they got erected in this grassy area, is one of the great wonders of the world, and people travel around the world to see these things. The island where they are found in the Easter Islands is called Rapa Nui. That's the name of the island, Rapa Nui. So somebody was in Rapa Nui checking out the local scenery and got this brilliant idea that he might strike gold if he brought some dirt back to America. Took back some dirt. I don't know if he had a Ziploc, but whatever little contraption he had at the time. He took back some dirt to analyze it to see if he could find a fungus that had never been found before that might make an antibiotic that was never found before, like streptomycin coming from Streptomyces. And people have looked in Africa and China, America, and everywhere in the world, but they never looked in Easter Islands before. And sure enough, just by the most extraordinary serendipity, he found an antibiotic that had never been found before. So he named it after Rapa Nui Island and called it rapamycin. Well, rapamycin then got tested in the great big cancer war that was going on to fight cancer at the National Institutes of Health. In those days, the NIH had tons of money, and they were able to do all kinds of things that you wouldn't think could happen today. But they had a program where any new chemical that got discovered like this could be tested in the laboratory to see it had anti-cancer properties. And what happened was that sure enough, it did. They took like 10,000 chemicals and put them on cancer cells and see which ones killed the cells. This turned out to be a winner. And it turned out that there was an enzyme in the cell that it worked on, and they didn't know what to call it, so they called it mTOR, mammalian target of rapamycin. That's mTOR. So, and what is rapamycin? It's an mTOR inhibitor. Well, it turns out rapamycin is a chemical called sirolimus, and Ernest made a user-friendly form of sirolimus and called it everolimus, but it's basically the same natural antibiotic. But it has tremendous anti-cancer properties, and especially for neuroendocrine tumors, where it was the first thing to be proven to be effective. This is a study that we did in pancreatic neuroendocrine cancer. Half the people got everolimus and half the people didn't. The people that got everolimus, the orange curve above, the chance of being free of recurrence versus time, you can see the everolimus people did much, much better than people who didn't get everolimus. It was a winner. Then for other kinds of cancer, in addition to other kinds of neuroendocrine cancer, not just one's pancreas, but now intestine and lung as well, a study was done and it turned out almost identical results. And it's another means of controlling neuroendocrine tumors. Now, this is a picture of blood vessels in a tumor. They're very weird blood vessels. They don't look like blood vessels anywhere else in the body, except maybe a placenta. It's very unusual blood vessels. And these are blood vessels that form inside of cancers that are called neovascularity. This is what anti-angiogenic drugs work on, drugs that attack the blood vessels of cancers. So a trial was done in pancreatic neuroendocrine cancer using sunitinib, which attacks these blood vessels. It was found to be just as good as everolimus. It's a pill, just like everolimus is. It works very well. It was published in the same issue of the same journal and approved by the FDA on the same day as everolimus. So for pancreatic neuroendocrine tumors, we have sunitinib and everolimus. For other kinds of neuroendocrine tumors, we have everolimus. Another drug I'm very excited about that we have in clinical trial right now is cabozantinib. Cabozantinib is a so-called tyrosine kinase inhibitor like sunitinib, but unlike sunitinib that seems to just work in pancreatic neuroendocrine tumors, this one works in carcinoids of all types and all kinds of neuroendocrine cancers, and the results from early studies are looking fantastic, with the average person with a carcinoid having cancer control for 31 months after they've had almost every other treatment known to man. And even in pancreatic neuroendocrine tumors, it still works in both kinds of cancer. It works very, very well. So this is in a large national clinical trial right now. Now, another drug I want to tell you about is chemotherapy. Chemotherapy for carcinoid tumors has turned out not to be very good at all. But for pancreatic neuroendocrine tumors, there are a few unusual chemotherapies that work very well. And one of the most user-friendly and nice kinds of chemotherapy for pancreatic neuroendocrine tumors is the combination of capecitabine and temozolomide, also known as Cape-Tem. This is oral drugs. They're given for in a 2-week period. You have sort of a complex schedule for taking them, but it all happens over a 2-week period. And then at the end of the 2-week period, you stop and you have 2 weeks off. But 33% of patients taking temozolomide and capecitabine had a major tumor shrinkage, and it controlled cancer in the majority. So this now has turned out to be a very effective treatment for example, treating somebody who might need to go to surgery but has a borderline operable tumor. This may shrink it to the point it becomes operable, or other situations in pancreatic neuroendocrine tumor where we need to see a tumor shrinkage. So we have a lot of different options right now for treating neuroendocrine tumors. The art is figuring out which ones to do when. And for mid-gut tumors, we have a long list of things. Pancreatic tumors, we have a long list of things, as I've mentioned. So how do we figure out what to do? So here's some of the factors that go into mind when you're thinking what to do. How extensive is the tumor? Is it localized or metastatic? If it's localized, maybe you could do surgery. Maybe you could do hepatic artery ablation. Maybe you could do ablation. But if it's metastatic, you need to do something to treat the body. Is the metastasis just in the liver, where it can be treated with liver-directed therapy, or is it widely metastatic all over the body and you have to treat the whole body? What is the pathology like? The more aggressive the cancer is, the more likely it might be to respond to chemotherapy, drugs, or other types of more aggressive treatments. The other thing to be aware of is that you have to use your head in considering how aggressive a cancer is. And that's what I call pace of growth. If you do a biopsy, which sometimes is just a very tiny needle biopsy, it may show that your cancer is a low-grade, slow cancer. But if you do another MRI or T 3 months later and the tumor's a lot bigger, maybe that biopsy was not representative of the whole tumor. It's just a little itty-bitty speck that comes out of the needle. And there's something clearly more aggressive. So you have to figure, what is the problem? Is the biopsy inadequate? Do you need another biopsy? Do you need a change in your treatment? But you don't just watch a cancer get bigger and bigger and bigger and not do anything as the biopsy said it was slow. We talked about the difference between pancreas and non-pancreas. A lot of special things are possible in pancreas, including using Cape-Tem chemotherapy. Whether the hormone function is happening or not, whether it's a functional tumor, the carcinoid syndrome, or other functional syndromes that we talked about, or not, is very, very important, because if you have a functional syndrome, you've got to get the carcinoid syndrome or the insulinoma syndrome or whatever it might be under control, because those could be very dangerous to life and also increase the risk of complications. There also, you have to consider the bulk of tumor. Are you having symptoms related to a large tumor mass that may force a large tumor mass to be treated quickly or removed surgically? Or do you not have symptoms like that? So you always have to balance toxicity versus potential benefit. You have to figure what the goals of treatment are. You're trying to stabilize this and shrink disease. And you have to think what you're doing very carefully. And again, why we have a multidisciplinary team. Now, the last thing I want to talk about a little before we open up for questions is carcinoid syndrome. So how do we treat carcinoid syndrome? If you treat carcinoid tumor, you treat carcinoid syndrome as well. Because if you don't have tumor, you're not going to be making the serotonin and different chemicals that cause the syndrome. But the way we treat it is to use somatostatin analogs, octreotide LAR or lanreotide, which will reduce the amount of serotonin drastically and usually makes carcinoid syndrome much better. Another thing we do is to reduce the amount of cancer in the body, as I mentioned. This could be with surgery, with embolization of the liver tumors, with ablation of liver tumors, anything PRRT, anything that reduces the amount of cancer in the body can make carcinoid syndrome better. Telotrestat is a fantastic, recently released drug for treating carcinoid syndrome. It's a drug which actually stops the neuroendocrine tumors from making serotonin very effectively, but it does not cross into the blood-brain barrier, so it does not reduce brain serotonin. That's a good thing because if you reduce brain serotonin, you can get very depressed. So it works on the body serotonin, and it can make people's diarrhea that is not responding very well to just somatostatin analogs like octreotide or lanreotide. If you add telotrestat, you can have much improved control of diarrhea. Peptide receptor radiotherapy has been proven to make carcinoid syndrome symptoms better. They may worsen in the first month or two, but if you look where things are 6 months later, a year later, flushing and diarrhea are markedly improved. Also, when people have carcinoid syndrome, you have to prevent and be sure that you are able to effectively treat carcinoid crisis. This is particularly a problem in people that are undergoing anesthesia that can trigger a release of massive amounts of hormones from the neuroendocrine tumor. It can make people's blood pressure drop so low they go into shock, and it's very difficult to get out of. So it's a dangerous situation that we try to prevent. And that can be done by using intravenous somatostatin analogs in the operating room. There are various techniques for treating that, but the anesthesiologist should definitely know that somebody has a carcinoid tumor and do everything possible to prevent problems. So I think that this is the end of my formal remarks, and I would love to hear what your thoughts are and answer questions on anything you like related to neuroendocrine tumors. Thanks so much, and a pleasure being able to speak to you.
Thank you, Dr. Wolin. Thanks
Thank
for this really thorough and very interesting presentation. You covered a lot of ground here. So we have several questions that have come in, about 45 questions. And so I'd love to hear your thoughts about these. I guess one of the first questions I'd like to start with is, do metastases metastasize? If so, why is it such a big deal to find the primary?
Well, we usually think metastases coming from a primary tumor, but they probably come from metastases also. I've seen situations where people developed a metastasis in the lung, for example, and lymph nodes right next to the lung and lymph nodes in the lung were involved. And you wouldn't think it would get to those nodes if it didn't get to the lung first. So I think metastases can happen from metastases, but the majority of them come from the primary tumor that somehow gets into the bloodstream. Cancer cells move around and they grow. The reason it's a big deal sometimes to find the primary tumor is not necessarily because it might make more metastases, because metastases have probably already happened anyway if they're going to happen. But the most important reason to find the primary tumor is because it may affect quality of life or affect therapy. For example, if you have a primary tumor in the pancreas and you can identify that, there are unique treatments for pancreatic cancer, neuroendocrine tumors, as we've talked about. So you might use things like temozolomide and capecitabine that you wouldn't use if it was an intestinal primary. And there are many examples like that. The other thing is that sometimes if you have a small intestinal primary, it can actually be developing a bowel obstruction. And even though somebody's having abdominal pains and the doctor says, well, your abdominal pains might just be because you have cancer, you actually might be having abdominal pains because you're developing worse and worse partial obstruction of your small intestine. And if you take the cancer out, it will prevent worse obstruction and also prevent bleeding and also make your pains get better. And so sometimes it doesn't make sense to do all kinds of fishing trips to try to find primaries when it's a little tiny primary and there aren't any fish in the water, and it's not going to change the management of metastatic disease. But if possible, we like to know what kind when it influences treatment or therapy.
Yeah, really good point. It does influence treatment or therapy even after it's removed, right? And I thought it was really interesting how you mentioned there were environmental factors in the very beginning of your talk that might contribute to NET. What do you think those environmental factors might be?
That's a really, really good question. We're trying to figure it out now. There's ongoing research on that, but we really don't know the answer yet. But I can tell you that there are certain states like Kentucky that have the highest cancer incidence in the country. They also have twice as much carcinoid as anywhere else in the country. There are places in California that are in, remote areas, relatively in the Central Valley, where people seem to be getting carcinoid. I don't know for sure the incidence has increased there, but it may be, and that may be true in other areas where there are lots of sprays of pesticides and herbicides. There might be some industrial chemicals. It might be something in our diet, but I don't think it's an accident that the incidence of neuroendocrine tumors has increased by 500% in a 30-year period. And even though a little of it is from early detection, we had colonoscopy and CAT scans and everything 30 years ago too. So I'm not sure that it's all just early detection. I think that there really is more. And I think that environment is probably playing a very major role. So if you could eat healthy and not expose yourself to too many industrial chemicals, it certainly isn't going to hurt.
Okay, so prevention is helpful. And there were two questions that came up in the realm of genetic testing, which is, let's see if I can get them up. When do you recommend genetic testing for NET patients? When might you recommend genetic testing for family members, like children or siblings of NET patients?
Okay, well, the second one, it'll be easy. We'll do that one first. You basically recommend testing of family members if the NET patient has a familial syndrome. In other words, if there's a type of cancer that runs in the family that the patient has, then you test the patient's family. If the patient doesn't have a gene mutation that can be inherited, then it doesn't make sense to test the family. So how do you find out if it's worth testing for gene mutations in a NET patient? First of all, if people have genomic testing, which is becoming more and more common, doing genomic profiles, there are things like Foundation One, Caris, institutional types. There's all different analyses of genes, and those tests sometimes will reveal a genetic or potentially genetic mutation. The other thing is that people have certain syndromes, like if you have MEN1 syndrome, where you have pituitary adenomas, parathyroid adenomas in the neck, causing high calcium levels in the blood, and also pancreatic neuroendocrine tumors. That's called MEN1 syndrome. And those people can also get neuroendocrine tumors in their lungs and thymus and other foregut sites. So people that have that syndrome should certainly be tested, and then the particular mutation can be looked for in other family members. Also, if somebody has one of those key kinds of diseases, like a pancreatic neuroendocrine tumor, and you have a few family members that have some of those other manifestations, again, test the patient and see if you really have the syndrome. A lot of people with pheochromocytomas is kind of adrenal neuroendocrine tumor, which we didn't talk about in this talk, but once in a while somebody will develop such a thing. Those really, it's worth testing everybody for genetic mutations because it's so common. People that have medullary carcinoma of the thyroid, which is part of so-called MEN2 syndrome, it's worth testing just to be sure. So I think it's going to happen more and more. Carcinoid tumors, like intestinal carcinoid tumors, it's not worth doing routine testing for genetic causes, since there are only maybe 40 kidrons in the whole United States who have it, and they know who they are because other family members have the same thing. But anybody who has a parent or a sibling or a child who also has a neuroendocrine tumor for sure should be evaluated for genetic predisposition to neuroendocrine cancer, to neuroendocrine carcinoid, hereditary carcinoid. And there is a Dr. Stephen Wank at the NIH who actually studies these and can provide additional testing for those rare families where it's present.
Okay. So you're saying it's worth a discussion with your NET specialist about whether or not to have genetic testing.
I think that's a great summary.
Okay. And speaking of tumor mutations, there were a couple questions that came up also about tumor mutations. If you could explain the process of tumor mutations and what causes tumors to become more aggressive, and the other part is, will all tumors eventually mutate to become more aggressive?
Well, all tumors mutate to some degree because tumors are made of cells, and cells reproduce by splitting into two cells, and they make 4 and 8 and 12 and 16. And by the time you have a detectable tumor, you literally have billions of cancer cells. And the chances are, when you have that many cell divisions, that a mutation is going to happen periodically somewhere. And a lot of the times when mutations happen, it doesn't make anything more aggressive. The cells might even just die because they're messed up from the mutation. However, if a mutation happens to make the cancer survive better in the body and become more aggressive, or it happens to make the cancer grow faster than all the surrounding cells, then that particular clone that comes from the mutated cell can start taking over. And you could end up, the longer that you have a carcinoid tumor, the higher the chances that something will end up leading to a mutation in rate of cell growth that makes it grow faster. So, for example, if you have a very slow-growing carcinoid tumor that you've had for 20 years, and it's starting to get a little bit faster at its growth rate, it may be because it's actually undergone a mutation. I've seen a few cases where a low-grade tumor becomes a real high-grade tumor that grows like crazy. That's extremely rare. It happens, but it's extremely rare. The more common situation is if somebody has a Ki-67 proliferation rate of 2%, and later on in their course, they might have 10%. It's still a well-differentiated neuroendocrine tumor, but it's a little bit faster growing than it started out. That's more common.
Okay. And are there any certain factors that turn on this change in the mutation process that would cause mutation?
Just theoretically, you can never really identify what it is in any individual person, but things like radiation, certain kinds of chemotherapy, can make it happen maybe a little bit more rapidly, although just time is the biggest factor, just the number of cell divisions that end up happening.
Okay. Yeah, so time. And another question related to that is, how do mutations change the treatment? And I guess you mentioned paragangliomas, for example, with SDHC, with head and neck paraganglioma. If you could also explain what SDHC is.
Well, this is a very, very specialized question that probably relates to one individual somewhere in the conference who has an SDHC mutation from a head and neck paraganglioma. But basically, about 1 out of 4 people that have head and neck paragangliomas have a mutated gene that they all have funny names like SDHC, SDHB, SDHD. And if you have a mutation in one of these things, sometimes it confers some unusual properties. If you have an SDHC mutation, it's more likely to arise in one site instead of multiple sites. It's more likely to be benign rather than malignant. But if you have any head and neck paraganglioma, you should always test for mutations. And if you find one, test other family members, because the chance of having a mutation in this population is fairly high. But that's the bottom line.
Okay. And there was one related question about if there, and you kind of touched on it, about if there are head and neck NETs, and are they rare, and do you handle them at Mount Sinai?
Well, we handle NETs from everywhere, but there are different kinds of primaries from the head and neck area. For example, you could have carcinoid tumors that start in the sinus, carcinoid tumors that start in the larynx, or carcinoid tumors that start in other head and neck areas. Those same areas could also make extremely high-grade, poorly differentiated tumors that are like small cell carcinoma. Neuroendocrine tumors that are very aggressive can also start in those same types of head and neck sites. So exactly how it would be managed would depend on what the site is, whether it be managed with chemotherapy and radiation, surgery, and various combinations. And they're very rare and very varied in their type. So it really depends on the detailed information in a particular person, and often a multidisciplinary discussion with a head and neck surgeon, radiation oncologist, and medical oncologist. And very often, all three of these modalities are needed to achieve cure in somebody who does not have metastatic disease yet.
Okay. So you're saying that a multidisciplinary NET program can handle head and neck NETs as well?
Yes. Mm-hmm.
Okay. And kind of moving along to that area of mutations, if tumors don't currently express somatostatin receptors, will they ever?
Okay, so the question, we want to clarify it because you read it perfectly, but it didn't come out in writing perfectly. If tumors don't express somatostatin receptors, will they ever? Okay. Somatostatin, the hormone which is secreted by neuroendocrine cells, and it has biologic actions, but it's a hormone. It's not the feature of a cell membrane. The somatostatin receptor is found on the cell membrane. And if you don't have, the way we find out if there's expression or not expression is usually by doing a gallium dotatate PET CAT. If you do a gallium dotatate PET, which is negative, it could be negative because the tumors are too tiny. Okay, even though gallium dotatate PET is very sensitive, if you have a tumor that's only a 1/16 of an inch across, it's probably not going to show. If it has, even if it has lots of somatostatin receptors. So this patient could be told your tumor is negative, you can't have any benefit from somatostatin analogs and PRRT or anything because you're negative. But 5 years later, you could do a scan when tumors are bigger and say, yikes, they're positive now. We could do all of these things. So one of the things you have to be very careful of is if tumors are too small for the resolution of the test. Every test has a limit of what they can pick up. We call it resolution. And you can't see it necessarily. Or sometimes it can be low receptors, and sometimes it can be a little higher. If somebody has absolutely no somatostatin receptors at all, it's very rare that it becomes positive. If you have a good-sized tumor and it just looks like a hole on a gallium dotatate PET with nothing there, you probably don't have anything. But one thing you should remember is a lot of times when gallium dotatate scans are read as negative, it's not because there aren't somatostatin receptors, it's because they're relatively low. The way it's done is they grade the tumors with a so-called Krennig score. Krennig score has to do with whether it has more somatostatin receptors than the normal liver and the normal spleen. And if it comes out with a low score, like less than or equal to liver, that's called pretty negative because you don't see a single tumor. Even if you have 5 tumors in the liver, you won't see any if the tumors have the same amount of receptors as the liver. But that means they still have receptors. It just happens to be the same as the liver. They still may benefit just fine from using a somatostatin analog for therapy. Okay, for PRRT, we'd like to see even more than that. But these things have to be interpreted carefully and with somebody who's experienced at interpreting, because you can get fooled. And conversely, you could think you have a tumor that has lots of somatostatin receptors, which isn't even a tumor. It could just be a false positive on a gallium scan, for example, in the pancreas that normally makes insulin, normally has neuroendocrine cells. You could see positivity in a normal pancreas.
Lisa, can you hear me? Tell doctor to re-sign on. I'm not sure what happened, but let's see if we can continue. Here he is. Hold on. Stand by. Stand by.
Saw her window.
Not sure, but we might be still streaming. Let me put you back.
Hello.
Hold on one second.
Hi.
Hold on one second.
I think we're just frozen on the
Hold on one second.
Facebook.
Hold on one second. Just let's see if it continues. Here we go.
Hello.
Hi.
we
Sorry
back?
about that.
We're working now?
Give
Yes,
us one
we're back
second.
live. Just apologize for the glitch.
I don't
okay.
know, but we'll continue recording.
Okay, we apologize for that glitch. So the question was, if the tumors don't currently express somatostatins, will they ever?
Okay, so we took care of that question, right? Did everybody
Okay.
hear?
Yes, and I guess a follow-up question and thank you for that very thorough response. It's helpful. I think a lot of people don't think about that if they don't currently have somatostatin receptors, it might just be too small. Follow-up questions is this: if you do not have somatostatin receptors, should you still have the gallium-68? And if not, what tests or scans do you recommend? So I guess, if you don't currently express the somatostatin receptors, would you recommend another one in the future?
Okay, so if you have a gallium dotatate PET CAT and it is negative for tumors that have somatostatin receptors, I would not keep doing it over and over and over. It still is a test with radiation. You have a CAT scan of neck, chest, abdomen, and pelvis and an isotope. And you don't want to just keep doing it for fun if it's not going to be helpful. So if it's negative, I would not, and a well-done scan that was properly read and it's really negative, I wouldn't keep doing it routinely. As I mentioned before, if the circumstances change, somebody has, recurrence of disease 5 years later, of course, if it's possibly influencing treatment in any way, if it'll make a decision whether you'll have PRRT or not, you do it again. But otherwise, it's not worth it. Okay? Now, how do you follow patients? You can't measure tumors on a gallium PET, a gallium dotatate PET. It's one of the most common mistakes I see, that people keep getting these over and over and over. They try making interpretations. The cancer is getting better or worse based on a gallium dotatate PET because it's such a great test. The problem is that you can't measure a tumor on that test. No radiologist in the world can measure a tumor on a gallium PET. I can't emphasize that enough. What it does is it shows that the tumors have somatostatin receptors. It could also show where the tumors are in the body, and you could find out you have tumors you didn't know you had. But the size can't be measured because a little tumor that has lots of receptors can make a great big area of brightness. You see? And a great big tumor that has low receptors can look like a small area of brightness. So that is not really very good. And the problem is the CAT that's done with it. It's done as a pet cat, not a pet dog, pet cat. You do gallium dotatate and you do a CT scan. The CT is done with no contrast usually when you're doing the PET CAT. You do it without contrast. And when you do a CT scan without contrast and you're looking for water density structures like water density tumors inside of a water density liver, you're not going to have very good luck because what's going to happen is that everything's going to look about the same. So you need the intravenous contrast to bring out the difference between what's tumor and what's not tumor. So I would say the best test is an MRI, usually with EOVIST contrast, which is a kind of contrast that shows liver tumors better than anything. And you could follow the tumors really well on that, an MRI of abdomen and pelvis, maybe a non-contrast CT chest to look at the chest, and you could use that to follow the cancer. Otherwise, you can do a CT scan of the abdomen and pelvis, but it really needs to be done as a triple phase CT, and it has to be done very carefully, or you could miss things that otherwise you would see on an MRI. But those are the things to do. Now, some patients that have pretty fast-growing tumors, you could sometimes assess the status by doing an ordinary PET scan, also known as an FDG PET. But again, I wouldn't do it over and over and over and over, but it sometimes will be helpful in staging a cancer or evaluating response to treatment.
Great. Thank you for that. And as you're saying, it's really important to look at the whole picture because the gallium-68 can't measure the size of the tumors. So there's several questions about somatostatin analogs. And one basic question is, for treatment, what do you prefer, octreotide or lanreotide, and why?
Wait a minute, what's this? So, do I prefer octreotide or lanreotide? Okay, each one has its pros and cons. One thing about octreotide is it's available in an immediate release form, which lanreotide is not. Lanreotide is not available in an immediate release form. So that means if somebody needs octreotide intravenously before going to surgery or during an operation, you could prevent carcinoid crisis by using intravenous octreotide. We can't do that with lanreotide because it doesn't have an intravenous formulation. Also, people who have carcinoid syndrome very often, in fact, I recommend it, have short-acting octreotide acetate, the short-acting form available. They could self-inject with a tiny needle. So anytime they're starting to get problems with diarrhea or flushing, or if they know something's going to bring on symptoms like physical exercise, they could inject before they do it. And it's a wonderful thing. For the long-acting formulations, we have octreotide LAR and a long-acting lanreotide depot. Most patients do prefer the lanreotide injection because it's a subcutaneous needle, which is much shorter than the deep intramuscular needle of octreotide LAR. But if people are already on octreotide LAR, they've been on it for years, they're happy, and it's controlling the cancer, you could keep doing what you're doing. If otherwise, I think there are certain advantages. Subcutaneous is also particularly good if people are really thin because they don't have big behinds to inject octreotide into. It makes it much, much easier on them. It's also good if people are really obese because octreotide injections can end up in the fat instead of in the muscle. So again, lanreotide wins. If people bleed easily, if they're on anticoagulants, anything that makes people bleed easily, lanreotide wins because it's just a subcutaneous injection. It's easy to put pressure on. It's not like it's way down deep in the muscles of the rear. So both medications are good. I think we're fortunate we have them both. And if somebody is on, and also I should say that even though most of the data comes from lanreotide in terms of its effectiveness as an anti-cancer drug, okay, if lanreotide isn't paid for by insurance or something, and the only way you can get treated with a somatostatin analog is with octreotide acetate, I don't want you to feel you're getting a horrible treatment that has no chance. It's probably just as good, even though we don't have the same amount of data to prove it.
So it depends on the patient. And you kind of already touched on this. Yeah, if there's data whether or not lanreotide shrinks tumors, you mentioned the clarinet trial, and if you don't have syndrome, is it necessary to keep getting the shots?
Lanreotide usually does not shrink tumor. In up to 5% of people, though, it can. So some lucky people actually have tumor shrinkage from lanreotide. And I've seen some people where it's been dramatic and just huge amounts of tumors just melted away. But most of the time, we think of it as a stabilizing agent that often stabilizes it for many, many, many years. Now, if you don't have a syndrome, is it necessary to keep getting shots? So that's a separate question. One is about shrinking tumors. The second part of the question is about syndrome. Okay, so if you have syndrome, you need to have injections indefinitely so you don't get complications of your syndrome, like carcinoid heart disease, like passing out from the insulin, making your blood sugar too low, right? But if you don't have syndrome and you're using the octreotide or lanreotide for controlling cancer growth, you definitely want to keep up the shots, even if you don't have syndrome. The clarinet trial was done exclusively in people with no syndrome because it was a randomization between lanreotide and placebo, and it was felt to be not ethical to randomly give people with syndrome no somatostatin analog. So that was a randomization in people who had no syndrome. And it proves that when you have that population with no syndrome, you can still keep tumor under control for many, many, many years with those injections. So I would definitely keep them up. It certainly has fewer side effects than need. therapies out there.
Yeah. Thanks for clarifying. I know that's an issue that comes up, or a question that comes up many times in the population. This question also comes up. What are some reasons that somatostatin therapies are not effective for some patients?
Just one sec. Well, what is the reason why somatostatin therapies are not effective for some patients? Okay, there are a lot of reasons. One is, of course, if you don't have somatostatin receptors. In the old days, we didn't have gallium dotatate, and people were just empirically treated with somatostatin analogs. Okay, and then sometimes it would work, and sometimes it wouldn't work, and we didn't know. But now we could tell in advance who's likely to succeed by doing the gallium dotatate. So one reason for it not working is not having the somatostatin receptors. The next reason for it not to work is that after being on it for many years, some of the cancer cells get smart, if you like. They have some clones that grow that have developed a mutation that doesn't be held back in their rate of growth by somatostatin analogs, and it doesn't work anymore. And that's why there's, after several years go by, they become ineffective. And almost anybody, they become ineffective. The average in intestinal carcinoids is over 5 years. But still, at some point, they become ineffective. And then at that time, you have to move on to something else.
Okay. And that's actually related to the next question. If there's a downside to start, or an upside either, to start and stop lanreotide, like taking a break, especially when things appear normal or stable.
It's not really a good idea because you're giving the cancer a chance to grow. Lanreotide only works when it's in the body, and the effects wear off after about a month, and then you don't have anything holding the cancer back, and it's going to start growing. And if you start it again in the future, you don't really know if it's going to work as well as it did before. So if things are stable, that's wonderful. Just keep it up. Instead of doing scans every 3 months, maybe you could do them every 4 months. Maybe you could do them every 6 months, but stay on the shots because they're good for you. Hopefully, before too long, we'll have some alternatives to having all these shots. There'll be some things that are more user-friendly that you can do yourself, or pills, or things you can self-inject. But right now, even though it's a little bit of a nuisance, it's less of a nuisance than having cancer growing in your body. So get a shot once every.
And related to that, maybe if things aren't stable, but you're on a different treatment, would it be recommended for someone to stop the monthly lanreotide shots during treatment, such as with CAPTEM? Or I know other people have asked about stopping during PRT, or any other treatment for that matter.
That's a really, really good question. And absolutely nobody in the world has a definitive answer. Okay, so here's the situation. Normally, when you have a cancer treatment that doesn't work, you say, okay, let's just move on and don't use it anymore. If capecitabine and temozolomide stop working, stop it. Do something else. Do PRT, do everolimus, do anything. But worthless chemotherapy is pretty worthless. However, when it comes to hormonal treatments, things are a little different. If somebody has prostate cancer and they're being treated with an anti-androgen, that's a sort of a standard thing to do for prostate cancer to keep it from growing. People use hormonal treatments that are anti-androgen. And let's say that after years go by, the cancer becomes resistant to that and they need chemotherapy. Normally, they stay on the anti-androgen because you figure, what if you stop it? What if the testosterone level gets really high and the cancer will start growing because some cells still have those androgen receptors? So people keep up the anti-testosterone medication and give chemotherapy at the same time because they don't want it to start growing faster. And that's a little bit like the situation with neuroendocrine tumors, where most specialists continue the somatostatin analog with the theory that if you have a strongly positive gallium dotatate scan and you have tumors with somatostatin receptors and you don't at least slow down the population of cells that is susceptible to being slowed down, it might grow even faster. But nobody has ever done a study where half of the people get continued somatostatin analog for life and half of the people you stop it as soon as it progresses. Nobody's ever done a study like that, and probably never will, and we don't have a definitive answer to that question. So experts disagree on that. People you, you just have to do what you feel. But I would say in most centers, if you just take a poll of carcinoid docs, most people continue the somatostatin analog.
During other treatments. Okay. And so related but unrelated is, what if someone has no evidence of tumors? Like, say they had, in this case, a patient had PRRT over 6 years ago, and the current scans, thankfully, shows no tumors. Is it necessary to still do somatostatin injections with lanreotide or octreotide?
Also a question we don't have an answer to. For years, the people were doing PRRT in Europe, and PRRT would be given and people would be sent home, and they wouldn't have any somatostatin analogs, and they still seem to do well. Other people went home after PRRT and got somatostatin analogs all the time. When it came to doing a randomized study to prove that PRRT works, the so-called NETTER-1 trial that I talked about a little earlier, where half the people got PRRT and half the people got double dose lanreotide, the PRRT people all had octreotide LAR 30 milligrams or equivalent after the PRRT in the United States and in Europe. Okay, Richard Baum and other major doctors in Europe were also co-authors of this project, the NETTER-1. So people on both sides of the ocean were getting somatostatin analogs, and it was felt to be the standard of care to give somatostatin analogs. So the study that proved how good PRRT is did use somatostatin analogs. So I think if we want to say what is the recommended standard, it's to use continued octreotide or lanreotide. But we also know if somebody has trouble tolerating it, they get severe problems with diarrhea, or they get allergic to something, or whatever it is, and they can't have it, I wouldn't push it. And if somebody's already got years without having any after PRRT and still doing fine, I don't see any reason to suddenly start it 6 years later. But in general, if people are okay with it, it's a good thing to do, I think, at least based on the limited data we have today.
Yeah. So if they can tolerate it, and it's a matter of continuing it seems like a good idea.
Yeah, you might as well.
Okay. And so there's some questions about symptoms. Can a general rash, can rashes be a symptoms of disease progression?
Well, rash is a pretty general word, and it can mean different things. In a pancreatic neuroendocrine tumor called a glucagonoma, for example, you can get a peculiar skin rash called necretory migrolytic erythema, which is a really unpleasant-looking rash all over the body. And if that gets worse, it's usually a manifestation of the cancer getting worse. You could also have people that have bad carcinoid syndrome for a long time, where all the serotonin is being made so fast it uses up the tryptophan in the body, and you end up with a niacin deficiency. It's called pellagra, a vitamin deficiency disease that makes the skin all red and dry, and it looks like a skin rash. And that can be treated with niacin, and it may or may not reflect cancer getting worse or growing, but just be aware of it. People also can interpret getting a carcinoid flush as a rash. And if that is a rash, then if that's getting worse and worse, the carcinoid syndrome can be getting worse and worse. And certain carcinoid tumors, particularly foregut types, like lung carcinoid and others, can make histamine, and histamine can make the body get all red. And that can be interpreted as a rash. And sometimes if the cancer is growing, the secretion of the hormone, in this case histamine, can be increasing. So there are a lot of things that really have to be discussed with the doctor. Yeah. And the question, rash indication to get a gallium dotatate, is really kind of a, it isn't automatic. You have a skin rash, you get a gallium dotatate. But I think it's really something that you need to discuss with your doctor about what is causing the rash and what you're looking for. But if you think the cancer may be progressing, that's one of the best ways to see if the cancer is progressing.
Yeah. Okay. Thank you for that. And related to what you were saying about carcinoid syndrome, what can you do about carcinoid syndrome diarrhea if it doesn't respond to lanreotide, short-acting octreotide, or Zermelo?
Okay. So you got some tough cases. Okay. So the first thing is, let's say it's really carcinoid syndrome diarrhea. So what else could you do? A very important thing to do is to get rid of cancer, because if you don't have cancer, you're not going to be making all the hormones that are causing all the diarrhea. So if there's any way you can have tumor cytoreduction, if you could have hepatic artery embolization procedures, if you could have PRRT, any of those things can make the carcinoid syndrome diarrhea much better. PRRT was proven to do that. I think I showed you that earlier, improving quality of life and also improving carcinoid syndrome diarrhea. So you can do all of those things. You could also use other types of anti-diarrhea medications. People have used almost any medication that's out there for treating diarrhea that goes from Lomodal to tincture of opium. There are things that can be done to help the diarrhea if it's severe enough. But the other thing I should say is that you have to be absolutely sure that you don't have other causes of diarrhea in carcinoid patients. Because if you have carcinoid syndrome diarrhea, you're almost always somebody who has a carcinoid of the small intestine, usually in the lower part of the small intestine that we call the ileum. And people who have ileal carcinoids, the most common operation that is done is called a right hemicolectomy. You take out the end of the small intestine and the beginning of the large intestine, and along with it, you have to remove the ileocecal valve, which is the separating one-way valve that separates the small intestine and the large intestine. Whenever you do that, feces from the colon can back up into the small intestine. The bacteria will start growing like crazy because the small intestinal contents have a lot of nutrients in them from food you eat. And next thing you know, you have a whole bacteria system going on in the small intestine, making gas and diarrhea. So you can get severe diarrhea that way. It's called bacterial overgrowth syndrome. And the treatment for that is not more and more anti-diarrhea medicines, but it's to use a non-absorbed antibiotic like rifaximin. You can treat with an antibiotic that kills bacteria that are in the small intestine. Another example is the ileum, the last part of the small intestine, absorbs bile acids, which are in the intestine. Bile is used to help digest fats. So if you have bile acids that are not getting absorbed in the distal ileum, it goes into the colon and makes severe diarrhea. So people that have that syndrome can be treated with things that are called bile acid sequestrants like cholestyramine and can stop diarrhea. So you have to make a specific diagnosis of carcinoid syndrome diarrhea and be sure that's all you're dealing with, because people get other things. Carcinoid patients also get antibiotics for different infections, and you can get Clostridium difficile that causes severe diarrhea as a bacterial infection in the colon. So be sure that this is all being sorted out. And if you're a primary oncologist or physician is unable to sort out these other things, see a gastroenterologist who knows about them and try to get to the bottom of the diarrhea. You pardon the pun.
Yeah.
Okay.
Hilarious. That's a really good point. And our next month's webinar will be on diarrhea alone. So as you said, there's a lot of reasons for diarrhea. So since you were one of the investigators for the NETTER-1 trial and PRRT, regarding Lutathera, what's the percentage that targets and couples with tumor cells in comparison to the percentage that gets attached to the somatostatin receptors of normal neuroendocrine tumor cells, or normal neuroendocrine cells? So tumor versus non-tumor cells.
But I think what it sticks to is going to be very similar to what gallium dotatate sticks to, because it's really the same molecule. The scan is done with gallium-68 dotatate, and the Lutathera is lutetium-177 dotatate. It's the octreotide that sticks to the cancer. So it's really going to be the same thing. Fortunately, most of the medication which is given is sticking to cancer cells, but some sticks to other cells in the body, and that's why you can get some side effects from PRRT. You don't use PRRT right off the bat as the first-line treatment, but if you need it, and you deal with the side effects, but there are some side effects. That's why people's blood counts can get low, because certain bone marrow cells have somatostatin receptors, and somatostatin can stick to them. So it does stick to some other things, but surprisingly, people do really, really well despite that.
Yes. And speaking of sticking to things, yeah, I know that there's now, and you've kind of touched on the exciting new trials, and there's several now out with radiosensitizers and Lutathera. So when is doing a trial with Lutathera and a radiosensitizer a better option versus Lutathera alone?
If you have a trial available and you feel adventurous, you can participate in a clinical trial of new PRRT techniques. In addition to Lutathera, lutetium-177 dotatate, people are using other molecules. There are receptor antagonists instead of receptor agonists. In other words, instead of just binding to the receptor, they can stick to it in a different way. That looks like it possibly is more effective, but also might have more toxicity. It makes blood counts get lower, for example, and has other side effects. So whenever you do a trial of a new thing, if you use a sensitizer like everolimus or capecitabine in combination with PRRT, there's a risk of having other problems in terms of complications, and we don't even know all the long-term complications. So you have to be a little bit adventurous. It's like, who would volunteer to participate in the trials of COVID vaccine? It looks really good, and if it works well and you don't have problems, that's just terrific. Everybody wants to be immune to COVID, but yet you have to sort of have the mindset that there is a risk of complications, and you have to just have a slight adventurous spirit. I think right now there are some clinical trials with PRT that will only be available if people have first had normal PRT and then it starts growing in the future. Then you can be eligible for a clinical investigative trial. And there are going to be trials like that coming up soon using different molecular targets on the cancer cell or different molecules for doing the PRT or doing intra-arterial chemotherapy or doing all kinds of other things. Right now, the best standard treatment is still PRRT. That's the one that's proven. And I'm very hopeful about clinical trials and always encourage people to participate in clinical trials. That's how we got PRRT in the first place. And that's how we got everything we have for treating neuroendocrine tumors. But you have to realize that there is always a risk and a benefit, and you have to just sort of see where you stand and discuss it with your doctor. But I wouldn't feel like if you don't have it. Yeah, go on.
So it depends on risk tolerance. Yeah. And it's
exactly.
worth, again, discussing. Yeah. And thank you for being the clinical investigator for many trials. And I think this is really an interesting question because you were a clinical investigator for both Lutathera and everolimus. So if this was you, right, you're offering both PRRT and everolimus as a reasonable next step, how would you advise us from the patient or caregiver end to go about making this decision about which one is best for us?
Well, I don't think it's just like a random coin flip which one you get. They're vastly different treatments, and you have to say, what are the pros and cons of each one? Let's say somebody has good somatostatin receptors. They've been on a somatostatin analog for years, and now it's progressing. Okay, so what do? This is why we have a multidisciplinary discussion for every single person that goes on PRRT. You have to say, where is it progressing? Is it progressing only in the liver, or is it progressing around the body? If it's progressing only in the liver, is PRRT the best thing to do right now? Is it better to surgically remove those tumors from the liver or ablate them? Is it better to do embolization and save PRRT for another day? Okay, if it's growing in different places and it's all over and it has strong somatostatin receptors, and it's strongly positive, there isn't any question you do PRRT. Everolimus is very nice when people have really slow-growing disease, relatively low-volume disease. You hate to put somebody through PRRT if they have little itty-bitty tumors in the liver that have gone from 2 millimeters to 3.5 millimeters. And they're just little teeny-weeny things, and you don't have anything else, and they're just sort of sitting there. And the nuclear medicine guy says, well, we can't really embolize them because they're too tiny. And PRRT would say, why should we use PRRT when you have all this little stuff? Is the risk really worth it? Everolimus is a very interesting drug. It's not like other types of chemotherapy. It's a targeted biologic. And as long as you adjust the dose properly, which is an art, to make it so it isn't toxic to take, most people can tolerate it if the dose is right. The challenge is getting the dose right. But it can often work for years. And if it stops working, you still have other options to fall back on. So it's a delicate situation. If PRRT is done too late in the course, sometimes it's too late. You can't do it when somebody's dying of cancer, and it just becomes too toxic. So you have to figure out what is the risk and what is the benefit. One of the things to remember about PRRT is that full dose PRRT is a once in a lifetime experience. In the whole course of your disease, you can only do it once from what we know today in general. That's a big statement. That means that if you do it now, you won't be able to do it again 5 years later. People can do repeat PRRT as a second time around, but normally it's only done with 2 cycles. If you want to have 4 cycles in a row of PRRT, you do that once, and that's it. And then in the future, maybe if your body's holding up, you can do another 2 cycles, but you very rarely can do more than that. There are a few anecdotal people in the world who've had zillions of cycles, but that's very, very rare. Usually it's not more than 2 in the future. So the 4-cycle PRRT, 200 millicuries times 4, 800 millicuries, is you do it once. And the question is, should you do it now? Or in a really slow-growing disease that can be kept under control for years with other stuff that's more mild and doesn't cause mutations and doesn't cause counts to get low and doesn't have a risk of leukemia and whatever can, even though it's rare, there are things that can happen from PRRT. Why do you want to do it right now when you could possibly do it later? So it really is a very important discussion about figuring out the sequence of therapies. But I don't think it's just a simple thing. You do studies on both, so you just, okay, you do this, do that. It's not like that.
It's not comparing apples to apples for sure. So I know you've been very generous with your time. If we could just take 2 more questions, would that be okay with you?
Anything you want.
Okay. So there's a big question about immunotherapy. How and when is immunotherapy effective in NETs?
Okay, that's a great question too. Immunotherapy has changed the landscape of cancer treatment for almost every kind of cancer in the last couple of years. It's really amazing, especially since people discovered immune checkpoint inhibitors. It's really amazing. And people are working on other kinds of things too. The people that respond best to immunotherapy are people that either have lots of mutations in their cancer, which makes lots of antigens that immune attack can be directed against, okay? Or they have what's called PD-L1 overexpression. PD-L1 is something that PDL sticks to, and the PD-L1 inhibitors tend to rely on those things. Well-differentiated neuroendocrine tumors, which means most of the things we're talking about today, don't have a high mutational rate, and they don't have PD-L1 overexpression in most cases. And the results of immune checkpoint inhibitor therapy have been pretty disappointing. People have done studies with nivolumab and pembrolizumab and PDR001, which is another new one that's come out. And the response rate is not very good. It's nothing like in malignant melanoma, and kidney cancer, and other kinds of cancer where you see really wonderful responses. People are doing experiments trying to overcome this resistance, trying to use them in combination with chemotherapy or other drugs, trying to figure out how to make it better. And I think that there is a little bit of experience in grade 3 neuroendocrine tumors that is very exciting. Grade 3 neuroendocrine tumors in the lung respond very well to PD-L1 inhibitors and PDL inhibitors, things like small cell lung carcinoma. But when you get the same small cell carcinoma arising in the colon or the stomach or the esophagus or some other place, that's the pancreas, that's not lung, the response rate is much less. There's the concept of using 2 immune checkpoint inhibitors at the same time, like nivolumab and ipilimumab. It's called dual checkpoint inhibition. And that seems to be good for neuroendocrine tumors, particularly ones that are more high grade in the body. There was one small study that looked very exciting, but waiting on more studies. It potentially has a lot of side effects, although most people can do okay with it. But I think we have to see. The jury's not out yet. And I think when other things are not working and we have either the ability to get these medications on clinical trial or otherwise, I think they're good things to consider, but I wouldn't say that they're ready for prime time yet. People are still investigating the possibility of doing so-called CAR T cells and other kinds of therapy, but again, it's not ready for prime time. It's still in the laboratory. People are still doing very early trials, and we don't know if it's going to work.
Mm-hmm. Thanks for that. And there was someone who asked questions about grade 3. patients and treatment. So I think that touched on it. So we'll just end with this last question, which is comes up often, as you know. Are there any supplements, whether herbal or vitamins, that might be advantageous for NET patients as part of complementary treatment that you would recommend?
Okay, so that's a pretty big question because there's so many kinds of NETs and so many kinds of complementary treatments. And I think it's a good idea to see a physician who has special expertise in this to try to match the right thing. And some complementary treatments are just very simple. Like some people find a tremendous nausea preventive effect from ginger. So why take Zofran pills if you can use ginger tea and get the same benefit? There are also herbal anti-diarrheas, and there are herbal complementary things. You have to be sure you're not making things worse or exacerbating carcinoid syndrome. And a lot of these things haven't been really studied, but there are things that may be helpful, and we just don't know. There are complementary treatments like acupuncture that can be very beneficial in pain relief, and many people can have benefit from that. So again, you need to see somebody who's a specialist in this and knowledgeable enough that they would understand what a neuroendocrine tumor is, because a lot of the people that are advertising complementary and alternative therapies don't know much about neuroendocrine cancer. And sometimes generalizing from other tumors, it's hard when you're treating a zebra instead of a horse.
Yeah. And I imagine it might be different too when a NET patient might be stable versus going through some, acute treatment regimen like, getting chemo, getting CAP-TEM, or getting PRRT, if you would recommend supplements or not at the same time.
Right. And there's also a treatment that, why don't I just mention real briefly, that sort of relates to what we've been talking about with immune therapies and different things, and that's using viruses that are toxic to neuroendocrine cancers, right? Oncolytic viruses.
A question came up about that.
People are always asking about that, so I'll just throw it out as another thing that's... Oh, look at that. You have it right there. We're on the same page. So the idea is that there's a kind of a virus which is pretty harmless to people that's called the picornovirus, which instead of sticking to respiratory cells like coronavirus does, it sticks to respiratory cells, this is one that sticks to neuroendocrine tumor cells. And it pops them and they die. That's what they mean by lytic. It means that it makes the cell kind of explode. Okay, so it's cytolytic to the neuroendocrine cells. And people have done studies in the laboratory with neuroendocrine tumor cell lines and things, and it looked like it was active. So a phase 1 study was done with neuroendocrine patients, 30 patients, something like 24 of them had carcinoid tumors. And the progression-free survival, which is how long the cancer was stopped in its tracks with this virus, was 5.4 months. Well, that's not really enough to write home about. It might have some activity, but it's not that terrific yet. So some bigger studies are being done. There's a big study going on in Uppsala using it in the intrahepatically, giving it in the hepatic artery. That's going on right now. And they first developed this in Uppsala. There's a lot of experience there, but still very, very early. It's not ready for prime time. So I think we just have to stay tuned. I hope it's going to turn out to be a winner, but it's really early. So I wouldn't give up therapies that have a proven track record at this point for that particular trial. It's a very early phase trial. It's not a trial which is advanced enough yet that we know it has a good chance of succeeding. But it might be a winner.
So the bottom line is that we should have hope because there's a lot of trials going on. There's a lot of people fighting on behalf of NET patients everywhere across the US and around the world. So there's hope for treatments. Okay. Well, thank you, Dr. Wolin, for this really generous time of question and answer. And we really appreciate your time, your presentation. We thank you for all you do for the community. Thank you. And back to you, Lindsay.
Thank you, Dr. Wolin, for your incredible presentation today. As a reminder, the full video will be posted on the LACNETS YouTube channel within the next day or so. You can rewatch this all back. To learn more about LACNETS and what we do, please visit lacnets.org. And be sure to follow us on our socials to stay up to date on upcoming events, net news, and more. Our website is www.lacnets.org. And we hope you can join us for our next live webinar on Tuesday, October 13th at noon Pacific time with Dr. Shirley Paskey from Cedars-Sinai. She'll be talking about management of diarrhea in neuroendocrine tumors. It'll be streamed live again via Facebook and YouTube Live. Thank you so much for tuning in today. We hope to see you next month. Goodbye, everybody.